Okay, so we did our presentation on postpartum hemorrhage. Our fishbone that we focused on addressed the improvement plan was the 4 T's, which are trauma, tone, thrombin, and tissue, which are the causes of postpartum hemorrhage. We specifically focusing on trauma, focusing on uterine trauma in healthcare facilities can take significant steps towards minimizing incidence and severity of postpartum hemorrhage in the patients. It is the leading cause of postpartum hemorrhage and accounts for up to 70 to 80% of all cases. Some examples of uterine trauma include overdistended uterus, prolonged labor, instrumental delivery, cervical tears, vaginal lacerations, and lack of medications. These interventions should be priority and started on the patient as soon as possible to prevent any incidents of postpartum hemorrhage. And then here we have our fishbone diagram. So our searchable question, it would be in women who experience uterine rupture during labor, does continuous postpartum nurse monitoring and early hemorrhage detection protocols compared to standard postpartum monitoring lead to earlier identification of complications and improved maternal outcomes? So our first article was the postpartum hemorrhage prevention, diagnosis, and non-surgical management. And it is a comprehensive overview of postpartum hemorrhage and prevention, diagnosis, and non-surgical management. And it emphasizes postpartum hemorrhage is the leading cause of maternal morbidity and mortality globally. Focusing on the 4 T's that we spoke about earlier. They focus on active management of the third stage of labor and providing initial interventions within the golden hour of diagnosis. These includes activating the multidisciplinary team, conducting rapid assessments of bleeding etiology, maintaining oxygenation, and establishing IV access for resuscitation of medications. They focused on hemodynamic instability, non-pneumatic anti-shock garments, and non-surgical interventions that could be implemented for pharmacological interventions fail. It emphasizes that PPH is the leading cause of maternal morbidity as well. Our next article is Postpartum Hemorrhage by Beanstalk. It focuses on prevention, diagnosis, and treatment strategies and emphasizes the 4 main causes, the 4 T's, and the approach of managing these causes effectively. They review the importance of active management and the third stage of labor, the use of uterotonics and non-surgical methods like the uterine balloon tamponade, and also administering uterotonics immediately after delivery to significantly reduce the risk of postpartum hemorrhage as well as any non-surgical methods. All right, our next article was the acute postpartum hemorrhage, and it discusses acute postpartum while emphasizing its causes, diagnosis, and management strategies. It specifically outlines common causes like uterine atony, trauma, and coagulopathies, and stresses the importance of early recognition and intervention. Initial treatment involves uterotonics, mechanical methods, like a uterine tamponade to control bleeding. The article also covers advanced treatments for severe cases, like surgical methods and resuscitation and blood products transfusion. These surgical interventions would be like uterine artery ligation, hysterectomy, or selective embolization. And these are considered only if all other interventions are unsuccessful. So acute postpartum hemorrhage focuses on the cause, diagnosis, and management of the strategies. Our next article was on postpartum hemorrhage protocols and benchmarks, and it emphasized the importance of standardized protocols in managing postpartum hemorrhage. It highlights how consistent evidence-based practice can improve care quality, reduce variability in treatment, and enhance patient outcomes. The assessment of hospitals' performance in managing postpartum hemorrhage by ensuring timely and appropriate interventions is very important. So the article describes the role of the interdisciplinary team and the ongoing training of implementing these protocols effectively to reduce maternal morbidity and mortality. It also shows us the future role of a CNL, our future role as a CNL, and how we'd be able to implement plans to decrease the occurrence of postpartum hemorrhage within our facility. And then our last article was a nurse-driven initiative to educate an interprofessional team about postpartum hemorrhage emergencies. And it discusses the nurse-driven initiative aimed at educating an interprofessional team on how to effectively respond to postpartum hemorrhage emergencies. The program emphasizes the importance of collaboration across disciplines to ensure the best patient safety as well as timely interventions. And the initiative focuses on enhancing technical skills, communication, leadership, and situational awareness, which are crucial in managing postpartum hemorrhage. They believe the use of creative educational strategies promotes staff engagement and elevates nursing practice. So simulations are shown to have a positive effect on the nurse's confidence level and the recognition and initiation of interventions in emergencies, which ultimately could be the difference between a life or death situation with a postpartum patient. So how the search guided our practice and interventions. So it guided us by giving us the best evidence available and explaining in detail the pathology and etiology of postpartum hemorrhage, as well as the nursing interventions that we would have to follow to care for these patients. Ultimately, it showed us that continuous monitoring and early detection of hemorrhage helped identify protocols that have promising outcomes in prevention of postpartum hemorrhage, as well as vigilant monitoring can improve early detection of complications and prevent morbidity and mortality. Okay, so our recommended intervention, the intervention that we chose is to educate the nursing staff and the patient regarding identifying early signs of uterine trauma and demonstrates a patient-centered intervention. This is important because for the nurse and patient to know what to look out for. So proactive interventions ensure the most effective and timely care. The goal of this is to improve maternal outcomes by reducing delays and detecting complications such as hemorrhage. Early intervention is associated with a lower likelihood of severe complications and preventing the need for a more invasive procedure like a hysterectomy or a blood transfusion. Why do we recommend this intervention? We strongly recommend providing the patient and the nurse with education regarding the early signs and symptoms of uterine trauma to the patient as well as the nurse by the care team for several key reasons. They're all rooted in improving patient outcomes, enhancing safety, and fostering collaboration between the healthcare team and the patient. This intervention allows them to be able to be more vigilant and proactive about seeking help if needed, as well as the nurse seeking help from the interprofessional team, like the healthcare provider, if they suspect that a hemorrhage is going to happen in the future. It can lead to early interventions and potentially reduce the severity of complications in the future.
For the Plan, Do, Check, Act implementation, the plan phase would involve defining the problem, so the postpartum hemorrhage, setting objectives, and developing the plan. Some of the stakeholders would be the nurses, the OBs, the patients, the CNLs, and primary physicians. The do phase involves actually implementing the intervention, monitoring the progress, and gathering any feedback. So that would include asking the nursing staff and the patients if they have any ideas on how things are going, and also monitoring the progress by looking at the statistics. The check phase is where the data is collected. So then we would compare the rates of postpartum hemorrhage before and after the interventions, measuring the time between identifying uterine trauma and initiating any implementations, and then reviewing the education. The act phase acts on the findings from the check phase. So we would refine the interventions if necessary, standardize best practice, and then share the interventions with other units and hospitals. So our global aim, we aim to improve the nurses and patients' ability to identify uterine trauma and increase risk for postpartum hemorrhage. To be in the labor and delivery unit, the process begins with educating patients and nursing staff to identify uterine trauma early. The process then ends with the nurses being able to efficiently identify uterine trauma from birth and communicate the high risk of postpartum hemorrhage with the physician. For specific aims, we aim to improve early identification of uterine trauma by having 100% of the nursing staff attending complete training within 6 months. We then want to reduce postpartum hemorrhage rates by 20% within 6 months by identifying uterine trauma early and communicating with the physician and promote early intervention. We then also want to decrease the need for blood transfusions due to postpartum hemorrhage by 50% within 6 months by implementing protocols to identify early trauma, and use medications such as Methergin and Hemabate, which will minimize the risk for complications such as blood reactions, infection, and prolonged recovery time. Our internal and external resources, we have patients, OBs, surgeons, anesthesiologists, midwives, doulas, L&D nurses, blood bank staff and lab, QI teams, and education departments. We look at external experts and consultants for protocol and development training, CME providers, simulation and skills educators, and support system for the laboring mother. For progress monitoring, we want to measure patient outcomes by looking at the reduction in postpartum hemorrhage rates, the reduction in maternal morbidity and mortality, and the reduction in blood transfusion rates. We then measure the processes by looking at the time, how long it took to identify uterine trauma, and the compliance with protocols. We also look at operations of the measuring the length of hospital stay. For education and training, we provide quizzes to the staff every quarter to examine their knowledge retention to see if they need further education or to see if they are able to follow the protocols. We then look at finances and resources such as costs of interventions and the utilization of blood products. For our Gantt chart, for the task, we first want to initiate by defining goals, forming a team, and defining performance measures. The CNL is in charge of most of that the first couple weeks. We look at protocol development and review by drafting protocols, reviewing and finalizing with all the stakeholders, and submitting protocols. The staff training, we then use the education department to develop training and conduct initial training, and then we assess knowledge retention through quizzes. And then implement the protocols in the clinical settings, collect some baseline data, collect ongoing data. We then do a midpoint evaluation and adjust anything needed to refine the protocols. Then continue with ongoing implementation to continue tracking postpartum hemorrhage and transfusions, checking in with staff. And finally, we have the final evaluation to analyze data and compare outcomes with our original goals. And then we continue with ongoing monitoring to develop plans for future improvements. Our evaluation plan. For the WHO, we have OBs, surgeons, and nurses documenting the clinical outcomes. We then have QI teams monitoring and analyzing these outcomes. For our primary measure, we have postpartum hemorrhage rate, which is greater than 500 milliliters for vaginal deliveries and greater than 1,000 milliliters for cesareans. Our secondary measures would be blood transfusion rates, maternal morbidity and mortality. This would all be looked at immediately after delivery up to 48 hours postpartum. We also look at how data is entered into the EHR. Transfusion data is cross-referenced with blood bank, and then we look at chart audits to check for protocol adherence. And that is all we got.